Inborners of Metabolism, you go to medical biochemical genetics. And I recently found out from the board that there are 136 people in the world that are board certified medical biochemical geneticists. Next. So what is a day in our life? So we have clinics. I have both. So I do general genetics as well as metabolics. We have clinical trials and as well as consults. Most of our consults are in the pediatrics part, and then we have adult consults. We do have two services, which is tricky at TGH because we have our clinical geneticists who do most of the consults, and then for suspected metabolic, we have our own service. And when we have someone that has a known metabolic disorder, the metabolic team rounds on the patient every day, and we have our metabolic dietitian. So it's a separate team. And sometimes suspected metabolic turns into a genetics condition and we transfer to the genetics team and vice versa. Next. Typically, people think about metabolic geneticists with the newborn screening, and that's fair because the newborn screening was meant for PKU, which is the most common inborn error of metabolism. And next slide. And it was, the PKU was the reason for the creation of the newborn screening, but now we do have a lot more than just PKU. This is just to show you that in the world, different countries have adapted or started the newborn screening, and the US started in 1965 with the creation of the PKU card, and then it just started with other countries adding. Next is I was born and raised in Puerto Rico. That's a small island in the Caribbean, and we started implementing the newborn screening in 1987. No, it's okay, just stay, don't go back. This is to show you that PKU was discovered in the 1930s and by Dr. Falling, and then it wasn't like 30 years later that it was found like a simple method to find babies with elevated phenylalanine so that you can treat them. So it took about 30 years for that creation of the newborn screening, which was implemented in 1965. And then it was later on, as you can see, the different dates that the congenital hypothyroidism was added, hearing was added in 2000. So many of us were not really screened for some of these disorders. The major breakthrough came in 2006 when they created a mass spectrometry, where is one simple small blood sample can give you many different disorders. And the most recent disorder that is added is MPS II, which in the state of Florida should be added in the coming months. Next. So we actually have over 40 disorders that we screen for. Every state is different and every country is different. And that is something to consider when you are treating a patient, because you may not know if they were screened for any of the disorders that we actually screen for in the state of Florida. Next. So this is the part that I really wanted to start on, is the cases. So we have, I chose some cases that all of them were treated at TGH. So I wanted to showcase cases that you all have seen at one point or another, and that I think are important to bring up the differential diagnosis of having inborn errors of metabolism that can present later in life. They not only present in the newborn period. So this is an 18-year-old male who was driving his car. He was previously healthy and had a stroke that caused a car accident. He was taken to the hospital and he was discharged on medications, antithrombotic medications, was followed by hematology, and was transitioned to 81 milligrams of aspirin. A few months later, he developed a severe headache. Next. And this headache was due to a new right frontal lobe stroke. He had multiple venous thrombosis and he developed seizures. He was transferred to TGH for thrombectomy. And the only thing he had was a past medical history of specific learning disabilities. If I remember correctly, it was math and reading. He did not have frank intellectual disability, just specific learning disabilities. Next. So when you think about this, I'm sure your differential diagnosis as an internal medicine doctor is super long, but this is my own differential diagnosis that I have when someone consults me on a patient with stroke. So we think about mitochondrial disorders, and many of you have seen some of our patients with MELAS, which is the mitochondrial encephalopathy, lactic acidosis, stroke-like syndrome. And they have stroke-like because they are not in the areas of vasculature. They are more like metabolic strokes. And you have congenital disorders of glycosylation, Fabry, which is a storage disorder, as well as late onset OTC, which is a urea cycle disorder, and your homocystinuria. So this is kind of in general some of the things that we think. Next, in our case, his physical exam, he was tall. He's 6'6", and he was wearing glasses. When, as a geneticist, when I think about this, I'm like, okay, tall stature with thick glasses. If there's one syndrome that comes to mind, I don't know how many of you already thought of it, but I have presented to the medical students at USF. So if there's any of them here, they may think about it. So we think about Marfan syndrome when we think about this, but this is more of a disorder that mimics Marfan syndrome, but could be very severe, and it is not Marfan syndrome. Continue. Our case, nobody had checked homocysteine. I want to say that like he was admitted a couple of times, he had surgeries, he had been discharged, and he didn't get anyone to check his homocysteine. It wasn't until he was seen by a metabolic geneticist colleague of mine in North Florida that someone checked a homocysteine. Next. And his homocysteine was 591. And as you can see, that's pretty abnormal. It should be less than 10. So when you see such a level, you definitely have to think that this is homocystinuria. Next. Next. Homocystinuria or classic homocystinuria is due to an enzyme deficiency. So for those of you that are more visual, the enzyme is the cystathione synthase, and that is the enzyme responsible for converting homocysteine to cystathione. And in this case, what we typically do, you could see the B6 there, it helps the enzyme. So some of the treatment is to give B6 because some of the late onset disease for this one or presentation, they are responsive to B6. And then you can also give other medications. We give B12 to help the conversion the other way around, to go back. So we take homocysteine and we convert it into methionine. And so we use B12 to do that, as well as another medication called betaine or cysteine. And that medication converts homocysteine to methionine to lower that. Next. This is from the first aid book. This is for step 1. I presented to the medical students because it actually is one of those conditions that they like to ask in step 1. Next. Homocystinuria has skeletal malformations that make them look like they have Marfan. So they have this Marfanoid habitus, but they don't necessarily have to look like Marfan. These patients have other things. They can have intellectual disability, but not necessarily all of them will have it. Our patient did not have intellectual disability. It is not always identified in the newborn screening. And if you ask why, the reason is because the metabolite that we use is not as sensitive for this particular disorder. So it's something to think about because they will often be missed by newborn screening. As a matter of fact, the patients that we have with classic homocystinuria have not been identified by newborn screening. And I've been here in Florida for 13 years, and I run the newborn screening program for this area. So we cover 14 counties, and we've never had one for classic homocystinuria. So it really tells you that they are going to be missed. They also have, this is the most important thing that I think you have to remember, they can have recurrent thromboembolism, and that could be the only sign that they can show. And that is because of late onset B6 responsive forms. So think about that when you have a patient that presents with the first episode. There could be all kinds of them. Next. This is to show you images of what it would look like. Next. But they also can have eye findings. And so some of them can have ectopia lentis as well as myopia, and they can also be that isolated sign. As a matter of fact, the patient that was presented that imaging, it wasn't from our patient, it's from a colleague of mine's patient. And that patient had a sibling, a sister who had ectopia lentis, and they didn't have a diagnosis. So when the patient presented with the stroke, this sibling got treated for homocysteine, or was identified for homocystinuria. Another thing to think about, they can also present with psychosis and psychiatric illness. Next. What do we do, and how do we diagnose them, and how do we treat them? The diagnosis is with total homocysteine and plasma amino acids, and we then go ahead and do DNA testing to confirm our diagnosis. But when we see a homocysteine of 500, pretty much is very indicative that we're talking about classic homocystinuria. And the treatment is to give B6 for those of patients that are responsive to B6, as well as betaine to convert homocysteine to methionine. We restrict their protein intake because when you break down protein into amino acids, one of the amino acids is methionine, and currently you are trying to convert homocysteine to methionine. So if you, on top of that, eat lots of protein, your methionine can go really high and it can cause cerebral edema. So we do low protein diets as well as supplement with formulas that do not have methionine. We work really closely with a metabolic dietitian for our patients that have these conditions. Next. This one, I wanted to showcase a very late onset. She's now 79, but she was 74 when she presented. She went to an outside hospital because this is how she's, the second time, which is the one at the top, which is when she presented altered mental status, she couldn't do simple tasks. What she explained is that she was living with her son at the time. She had lost her husband the year before, and so her adult kids, her son and her daughter, were taking care of her. And so her son was with her, and he said, "Hey, Mom, put your jacket on." And she went and got the dog's bed and put it on top of her like it was a jacket. And that's when he said, "Okay, what year is today?" And she was like, "It's 1920. So he said, "Okay, we'll go to the hospital, but this time we're going to go to a major hospital," because the first time that she presented the month before, she explained that she woke up and she was trying to make coffee and she couldn't make coffee. She could not figure it out. It was something that she does every day and she couldn't figure it out. And then she became slurred speech, and they took her, and that's when they said, "Oh, she has high ammonia." They gave her lactulose, treated her, but discharged her home with a diagnosis of a closeted alcoholic, even though she doesn't drink alcohol. So the second time around, her son was like, "No, we're taking you to a major institution." Next. In this case, they checked her ammonia, and her ammonia was 200 micromoles per liter, which is important to look at the units. There are other units that are not international and can be confusing. She was diagnosed with acute toxic metabolic encephalopathy, and this second hospital was more knowledgeable, and they did request amino acids and call the metabolic team. And so in these amino acids, they found that she had high glutamine and low citrulline, which was pretty telling. Next. When you think about altered mental status, some of the things that I think about are urea cycle disorders, because ammonia can give you altered mental status. I think about homocysteinurias. I think about organic acidemias, as well as mitochondrial disorders. Next. In our patient, well, because of those amino acids, we know that this patient had a urea cycle disorder, but it's a little difficult to know which one. This is the beautiful urea cycle disorder that you do not have to memorize. That is why you have your metabolic geneticist or your books to look for the urea cycle. But in this case, this is to show you that to kind of like review with you the importance of the urea cycle. When we eat protein and we're breaking down protein into amino acids, those amino acids have nitrogen. And that nitrogen is multiple molecules of nitrogen are what is considered the ammonia. Ammonia is neurotoxic and you need to get rid of it. So the body has a beautiful cycle called the urea cycle. And this cycle needs several enzymes to get rid of the ammonia in the form of urea. So it goes through different steps until you get to the bottom, which is the urea, and you excrete it in the urine. In the case of this patient, this patient had two variants that were in the CPS1 gene, consistent with a urea cycle in the proximal part of the urea cycle. Very rare that they present this late, but it can happen if you have enough residual enzyme activity that you don't have major episodes. Next. The urea cycle disorders are the most common cause of severe hyperammonemia. We're not talking that these patients show up with an 80 or 100. They are typically at 200 or above. You know, we've seen people with 800, 900 ammonias. This causes brain damage, so you have to act really, really fast, because once you start that high ammonia, it's toxic, it causes encephalopathy, and it causes cerebral edema. So we have to act quickly to preserve the brain function. Next. The typical clinical presentation for patients with urea cycle disorders is typically, this is what comes in step 1s or boards that I teach the medical students, is that they have normal pregnancy and delivery because they have been protected by their mom's metabolism. And then they're born and they start kind of like having poor feeding and progressive lethargy because they're becoming toxic. They are trying to get rid of the ammonia as they are eating breast milk or formula, breaking down that protein, creating that ammonia, and they are unable to get rid of that ammonia in the form of urea. So it's that typical presentation. However, if they have enough enzyme activity, they can present later on in life after having episodes of an illness or a surgery, or if they have they're being NPO for surgery. I've seen patients with bariatric surgery that present at that age, or postpartum, and or after a viral illness. That's when they present. The diagnosis is made by, first you check ammonia. If you have a urea cycle disorder, you have to have an abnormal ammonia, but notice we do not, they have to be corrected. You know, like in an acute event, you will have, in an acute episode, you have a high ammonia, but then we treat the problem and the ammonia should be back to normal. So we check, how do we know which type? This is by checking amino acids and orotic acid, and it let us know where in the urea cycle is the problem. Next. The treatment typically is to restrict protein, and also we have to give the patient a way to get rid of that ammonia. They don't have a urea cycle, so we give them an external urea cycle. We offer them a nitrogen scavenger drug, which is that medication that is basically life-saving for them. Every time they eat or whatever, they need to be on this nitrogen scavenger drug to get rid of that ammonia. Liver transplant can be curative, but if we can treat with diet on medication, we try to stay away from giving them a new liver unless they're not responding to medications and diet. And for those of you that are in like a ER, you need to know, how do you keep them alive? Because right now you're at TGH, where we actually carry all of the medications needed to rescue someone with a metabolic disorder. But if you're working at an outside hospital in the middle of nowhere, you may not have any nitrogen scavenger drugs. And what can you do to keep your patient alive? So the one thing to remember is to give them glucose. In the adult world, we give them 1 to 2 mLs per kilo per hour of D10 with electrolytes, depending on their chemistry. You can add potassium and have normal saline or whatever you need to add, but you need to give them dextrose. That is going to help them stop catabolism and stop breaking down protein, so the body can stop making ammonia and you can lower the ammonia. We also use insulin drip, and I see a lot of times in the adult world, I get asked, can we tweak down the IV fluids? The patient has high glucose and you're giving them a high glucose load. And my answer is no. The answer is go up on your insulin drip. We want to overwhelm them with sugar because one, we have to give them calories to stop catabolism, and two, because insulin also helps us with anabolism. So we're using that insulin in two ways that will help us stop this metabolic decompensation. Of course, the minute that we can, we're going to try and back off as soon as we can, because the enteral way is the best way to treat these patients. But in a moment of an acute metabolic decompensation, when your ammonia is high, we are going to use dextrose as our lifeline. And that means you may have to use the insulin to help us with that metabolic decompensation. And sometimes you can use dialysis. Next. So quick thing before we go to the 37-year-old. Some people ask, like, when do you know if you need to do dialysis, and when do you decide medications versus dialysis? Well, in the pediatric world, dialysis is a big thing. I feel my interactions in the adult world tell me that you guys are easier on the renal dialysis situation that it is in the pediatric world. For us, dialysis is like a big thing and everyone is afraid of it. And so we try to stay away from the dialysis and we try everything. But if your ammonia is 800, most often you will need dialysis to lower that. If the ammonia is in the 400, 500 range, with all the things that we throw at them, calories, insulin, dextrose, intralipids, we try everything. We may get to a good level, but we have very limited time. It's like the clock is ticking and we have to lower that ammonia fast. So in the adult world, what I have noticed, at least in the outside hospitals, is that they are quick to put them on dialysis while they're waiting for the transfer center. So, sometimes you may do the dialysis before I would have pulled the trigger. I typically would do these medications, but I also understand when they are out there 3 hours from us that they don't have any of these medications. Maybe they can do the dialysis while they're waiting. And if it's 3 hours to come here, it's a good call. In a case like this is a 37-year-old who presented with altered mental status. She went to the ER with agitation. Her husband took her. A few days before, she had a diagnosis of bipolar. And for a few days, she wasn't taking her medications because she was throwing up. So that kind of was tricky because the husband didn't know if she was having problems because of the medications or if it was because there was something else going on. But he showed me a video of her when she was having this episode at the outside hospital, and she was very out of it, agitated, and she was tachypnic, and they didn't know what it was. So they say that she had been having these episodes for the past 3 years, and they had been triggered once she was in a car accident, once she had a viral infection, and upon further inspection, she had been sick with, I remember now, with her period. Sometimes it would make her kind of like more lethargic than usual. So these were her triggers. Next. What is the differential diagnosis? It's very similar. The other one was a 74-year-old with these altered mental status, and this one is a 37-year-old with altered mental status. So same kind of thing, urea cycle, homocysteinurias, maybe organic acidemias, mitochondrial disorders. Next. And so in this case, we had an ammonia of 235. Next. And she was diagnosed with acute toxic metabolic encephalopathy secondary to possible OTC deficiency, which is the most common urea cycle disorder. The tricky part is that, and she was sedated and intubated. They contacted a metabolic doctor, and they kind of had a conversation about this patient, who they said, okay, this looks like a urea cycle, and send them to Tampa General. So they called us, And we were like, okay, ammonia of 235 and the presentation. So please start them on the dextrose because we need to stop catabolism. And do you have this medication? No. Do you have this one? No, no, no. Okay, send them. But she was 3 hours away. So this is one case where they actually gave her, they did dialyze her while they were waiting for the transfer, because I don't think we had a bed at the time. And then when they found the bed, they transfer her. Next. And so she was transferred next to DGH. And in a case of a urea cycle or on a high ammonia, you have to think again, like what is your goal? So first, emergencies, that's for you guys, ABCs. And then for us, our metabolic ABCs are to restore anabolism. This patient is in catabolism, so we have to go back to anabolism. We have to restore their metabolic balance. Many times we're going to check a blood gas to see where we are. And we also consider what conjugating agents can I use. In a case with high ammonia, I'm going to use a nitrogen scavenger drug, and we give dextrose, like there's no tomorrow in many of these patients. Then we say, please check what the other, like what caused this, because it's not, we will treat the ammonia, but please go ahead and treat everything else and obtain any diagnostic samples that you need. Next. So she was tricky, and this is why I'm bringing her up, because when she was presented to me, they were like, oh, we have a suspected OTC, and she has a high ammonia, it's a female, classic case of a late onset OTC. And I said, okay, sure, like bring her, we will do labs and we will figure her out. Well, it turns out when we looked at her labs, I can't because I'm in my phone, but I will show you like here that some of the things that were striking to me were her BUN is normal, like a 10. I typically look at the blood gas the anion gap, because if it's an organic acidemia, there's high organic acid that is going to be there in the anion gap. So that anion gap is going to be elevated. But this one is normal, so it's not an organic acidemia. And I look and I'm like, oh, elevated liver enzymes, that could be, typically like a urea cycle, could be any of them. But that BUN really bothered me. And so because BUN, blood urea nitrogen, I told you from the urea cycle, you need those enzymes to make urea. So you're telling me that this patient has a urea cycle, but they're making urea. So it just didn't sit well. So we said, okay, can you give me a CPK? And the CPK was 571, which this is after she had been dialyzed. And the ammonia had corrected, and we checked homocysteine, of course, because we wanted to make sure it wasn't one of the homocysteinurias, although those are not typically presenting with high ammonias. But is it two things at once, like the altered mental status? So we checked, it was normal. So this was tricky, and we said, okay, with this high CPK, there has to be something else going on. And so we ordered next carnitines and isocarnitines, and they showed low concentrations on most of the isocarnitines, and the free carnitine was extremely low. And at that point, you think, is it low because there's a secondary cause of deficiency, or this is primary carnitine deficiency presenting in the adult onset with hyperammonemia? Next. And so we did DNA testing, and we found out that she had one pathogenic variant in the gene that causes primary carnitine deficiency or carnitine uptake deficiency. Those are synonyms. And so we're going to talk about that now. Next. Carnitine deficiency or primary carnitine deficiency. When you think, so we just talked to you about protein metabolism, and we talked about the urea cycle disorders causing the high ammonias. She has a high ammonia, but it's not due to the urea cycle being damaged. It's a secondary cause of her high ammonia. So at this point, we're trying to find out what's going on, and carnitine is part of the metabolism of long-chain fatty acids. So I want you to switch gears now, forget protein for a minute, and let's think about fat metabolism or lipid metabolism. So when our bodies are fasting or stressed out, we have to use glucose because it's easy, it's the first thing our brain uses, but then we run out of glucose, and the next thing you need to create a secondary fuel. And our bodies are beautifully equipped with enzymes that will make ketones because that's going to be our secondary fuel. So we use that fat metabolism, we break it down, and we create ketones to save our brains from not having glucose. So carnitine plays a good part because carnitine binds those long chain fatty acids to go, it binds to them and it brings them into the mitochondria to be broken down little by little to create those ketones. So when you don't have the transport to absorb the carnitine, you run into trouble because you cannot have carnitine in your body to help the carnitines inside the mitochondria. Next. And so patients with this condition have different presentations. It's very, very tricky because they can start early in life, literally in newborn, with decompensations, lethargy, poor feeding, hyperammonemia, to childhood presentation of myopathy and rhabdo, later on pregnancy-related decreased stamina, cardiac arrhythmias, fatigability in adulthood, and people that have absolutely no symptoms. Like about 8 years ago, we had a patient in TGH who was a 25-year-old, required a heart transplant because he had cardiomyopathy and he had not been taking carnitine. So nowadays we put them on carnitine and we haven't seen that they progress to the cardiomyopathy phenotype. But if they're not identified, they may progress if that's their phenotype. But then we have moms that we find out because their babies have an abnormal newborn screen, and when we check the baby is fine. The baby was just reflecting mom's lack of carnitine. We check the mom has carnitine deficiency, and they have absolutely no symptoms. So we don't know. It's very difficult to know which one is going to be, but we treat everyone the same because it's such a simple treatment, just supplemental carnitine. We basically overload them with carnitine to help the transport, if there is any transport there, to help go through that transport. Next. So the problem is the diagnosis we have to do is biochemical because we check plasma and urine for carnitine levels, because the DNA only picks up 70% of cases. So 30% of our patients, we can only find one mutation and we don't find the second hit. In our case with her, we only found one hit. So we just had to go through the biochemical testing to give her the diagnosis. And the treatment is enough, is levocarnitine. Next. This was a 45-year-old male who presented with rhabdo, but actually he presented to an outside hospital with a diagnosis. The only thing is they didn't know what the diagnosis was. So he had CPT2, which is a fatty acid oxidation disorder, and he had a whole lot of problems. And this is not common in pediatrics. So for us pediatricians, it is overwhelming to see a problem list of 10. So this patient had diabetes, sleep apnea, depression, hypothyroidism, and I'm pretty sure I omitted a few other diagnoses there because it would take too long. But he presented to the ER because this is how he presented. So he went to Disney World with his family. He spent about 4 hours at Disney, and he just couldn't walk anymore, felt really tired, told the family he had to go home. They went home, and for the next 2 days, he couldn't get out of bed. He didn't feel well. He had generalized muscle pain, shortness of breath, and felt very congested. This is when the wife said, "We're taking you to the ER. You don't look so good." Yeah, but let me tell you, they already had the diagnosis. They already had seen us once in clinic because they moved from somewhere. So there was diagnosis. We had told them, call us if you're sick, but no, they didn't call us for 2 days. They just presented to the ER at an outside hospital about 2 hours away. Next. Well, what happened was he had a cardiac arrest and he had to be airlifted to our hospital. His CPK was 49,000, which is not terrible. He had higher in the past, but he was in bad shape. Next. And so he had been diagnosed at 40 years of age with CPT2, but he had been having symptoms since he was 6 years old with these diffuse muscle pain and nausea and vomiting. Sometimes he would have the urine turn brown, and he had been repeatedly hospitalized since the age of 18 because he had episodes of rhabdo and required dialysis, and nobody knew why. Next. And so this is kind of like to show you the approach, but I just wanted to share with you my experience with this patient, because the metabolic team would come, we showed up, he had been airlifted, oh, he has CPT2, this is one of your patients. So we went in, and I felt overwhelmed. When I looked at him, he had ECMO, he had dialysis, he was intubated. There were so many tubes coming out of this man, so many lines going in and out. There were a lot of nurses taking care of him, just him. And so here I go with our dietitians. We felt this big, like, what are we doing here trying to help when he's like not in good shape? So we were like, can we do TPN with this? And the nurses would look at us like, who are you and what do you want? So we would be like, well, can we do these? And just like little by little, we started adding little things. When they told us, yes, you can use enteral feeds, that's when we like opened the gates. He had been using MCTO, which was what we had available at the time, but we had a clinical trial for a different oil that had not been FDA approved. And because of his illness, I requested emergency therapy for a non-FDA approved drug, and we put him on our clinical trial next. And so over the next few days, he had was off TPN. We were able to give him his feeds, and he was on ECMO for a while. And then he was off ECMO at day 16, and he was discharged at day 38. I will say I have a lot of respect to all of the people that took care of him. I did not know, I don't know how you do it every day with all those things that are happening at the same time. We just focus on his diet and his fluids and his nutrition and his CPT2 while you guys fixed, because I would look at the x-rays, and I was very appreciative of the fellow that would walk me through the things that you were doing to understand what was happening with him. But luckily he did very well, and he's still with us. Next. For fatty acid oxidation disorders, I have a lot of respect for these disorders because they can actually present with multiple different systems involved, from peripheral neuropathy to rhabdomyolysis, cardiomyopathy, hypoglycemia. They can have retinal, progressive retinal dysfunction. So they can have a sudden death. Next. And they can present from pregnancy, in utero, all the way to adulthood. But we're going to focus on adult. Next. And so for adults, the most common presentation is going to be rhabdo, arrhythmias, and myopathy. I will tell you that I have lost a couple of patients to fatty acid oxidation disorders, and there was like a teenager who the mom explained, typically he would get a shower before going to the hospital because he knew he was sick, his legs were hurting. And so he would say, Mom, let's go to the hospital, take a shower and go. The time he died, he couldn't take the shower. He said, Mom, let's go now. I don't feel so well. So he had an episode, a cardiac event in the ER, and he coded. So this patient go from being kind of fine to zero, they just really go downhill quickly. And there's nothing that we can tell on the phone. So I'm very conservative when I send them to the hospital to get a CPK check, to give them IV fluids, because they may not need it, but we may be saving someone by sending them to the ER to get dextrose and labs checked. Next. The clinical manifestations of these disorders are typically the hypoglycemia, but it's hypoketotic or normal ketotic, meaning they don't make the ketones like they should when in the face of hypoglycemia, the cardiomyopathy or the arrhythmias, and the rhabdomyolysis. Next. And we diagnose with blood, we typically do acylcarnitine and carnitine. We check amino acids when we don't know exactly what we're dealing with, but we don't use amino acids for fatty acid oxidation disorders. We use urine organic acids and ketones, and the functional testing is like old school, where we have them, but we don't use them because many times you need skin biopsies, and people are not doing skin biopsies as much anymore. We do DNA testing. Next. The goals typically, like I said, ABCs, metabolic ABCs, and treat intercurrent illness. Next. With these patients, we do IV fluids with dextrose. We use enteral feeds as much as we can because that helps us use the ratios of fat intake. So we have to calculate how many calories are coming from fat, and we typically decrease the amount of long chain fat that they have in their diet, and we offer medium chain fat. Next. This is one that I presented. I presented a few years ago, internal medicine grand rounds. It's a 22-year-old, just to refresh your memories. This was in 2016 when she presented. She was living with her boyfriend, and he found her basically sitting on her. She had, lost her bowel function, bowel control. She was disoriented and had slow speech. Next. And so the tricky part is that they did labs and everything looked good. Like, she had a pernicious anemia history, had been on cyanocobalamin injections. Her B12 was normal, but if you can see there, her hemoglobin was low, her MCV was high. And next, they checked her methylmalonic acid and her homocysteine, and her homocysteine was 123 when it should be less than 15. Her methylmalonic acid was normal. This is when they called hematology, and they were going to do bone marrow, but the fellow contacted me. They didn't know if I existed or not. I think this fellow Googled online metabolic geneticist, and they found me by email and said, I have a case that we're taking to bone marrow tomorrow. Can you look at the labs and tell me if this is metabolic instead of us taking her to do a bone marrow? When I looked at it, I said, definitely she has a cobalamin disorder. And yes, she had cobalamin E, which is extremely rare. There are less than 20 cases, and we have 2 in our clinic. They do we give them hydroxycobalamin injections, which are more expensive than cyanocobalamin because they actually work and they are more active. We give betaine to convert homocysteine to methionine, and we give them folinic acid. Next. This is to show you. So for those of you that don't remember how you use B12, we ingest B12 and we have to activate B12 in 2 active forms. And all of those steps have our enzymes. So if you're missing any of those steps, it could be an inborn error of metabolism. In the case of cobalamin G or E, we have at the bottom the conversion of homocysteine to methionine, but that's why they didn't have elevation of methylmalonic acid. Next. And so the results, just to show you, when she presented, the neurology resident asked to have a clock drawn, and we started her on hydroxycobalamin shots. Next. And so this is her drawing next of after a week of medication. Next. Not everything that we have, it has a happy ending, and this is to show you a 43-year-old that had a history of an inborn error of metabolism. He was diagnosed in the newborn period, never had an episode before, had a stroke, went to the ER, was having a GI bleed. They put him NPO. The mom kept calling from Boston saying, my son has an inborn error of metabolism, please transfer him. But the hospital did not want to transfer until he became comatose. Next. And they basically transferred him. It was too late. We tried, but he didn't make it. Next, he actually had maple syrup urine disease, which is a treatable metabolic disorder. And next. Well, in general, you want to make sure you give glucose. We typically do 1 to 2 mLs per kilo per hour of IV fluids with dextrose. Anything is better than normal saline. So if you are working at an institution that doesn't have D10, use D5. Anything with dextrose would be better than nothing. We typically stop whatever they're eating because if we don't have a diagnosis, we don't know what's causing the problem. But we are in a time limit. We have to start them back on diet because they can become catabolic if we don't give them food. So we have to start the diagnostic process. If they have a fatty acid oxidation disorder, we cannot give them intralipid infusion. And then we use medications to bind different substances. Next. The wrap up is, please don't meet a treatable disorder. Act quickly and call your metabolic geneticist. Next. Thank you. And I am so sorry that I kind of ran through all of that, but I just wanted to make sure we covered all of the cases. And I appreciate your patience with the beginning of the grand rounds.
Go ahead and take the mic if you have any questions.
Okay, looks like no questions. Well, thank you so much for having me. And
Amarilis, can you hear us from TGH? It's Erica. But
yes,
we
I
have
can
we
hear
have a whole bunch of the residents and stuff here. Thank you so much. Literally, our team is taking care of your patient right now with the propionic acidemia. And we were reflecting some of the cases you presented. Some of us remember from their care here at TGH, and I know of like a dozen more super interesting cases from over the years. And so I really thank you for doing this. I think it's a really important resource that most people don't realize we have, and you're fantastic, but don't realize your contact and everything like that, and how easy it is to communicate and use your services. And even on cases where in the end, sometimes it's just regular old encephalopathy. I know you've always been really kind to give us another opinion. So I would encourage everyone to use their services, because they never say, no, you're wrong, it's nothing, you shouldn't have called us. They always are really thoughtful in their evaluation, and it's really appreciated.
Thank you, thank you. Yes, you are taking, actually, there are 2 patients currently in-house, and one of them I presented. Thank you so much for having me, and it's a pleasure, and anytime, please call us. There's also secure chat. If you have questions, don't hesitate to reach out.